Good morning. Welcome to the second day of the Healthcare and Life Sciences track at TC18. Did you guys have fun with devs on stage? Yeah. Show of hands. Awesome. So before I start, I'm Andy Day. I'm the Senior Director for Strategy and Marketing for Healthcare and Life Sciences. Been at Tableau for 4 years. Take humble pride in being the architect of the Healthcare and Life Sciences track, and so it's personally gratifying to see it growing by 25 to 30% every year. We clearly have to request a bigger room next year, which is a good problem to have. So before I get started, I'd like to take a minute to point to my colleague, Mark Norato, who is Senior Director and our new leader of sales, and my passionate partner in crime in taking the healthcare business to the next level. Really ecstatic that he's joined us from Infor about 6 months ago and leads our sales team. So with that said, just a little bit of background around the Healthcare and Life Sciences track. We really created it about 4 years ago in really response to the articulated needs of our customers about having a forum for successful customers who have deployed Tableau to share their best practices that the rest of the community could learn from and take away with them. And so what we have tried to do, there's actually very systematic method to the madness in terms of how we choose our presenters. It's fairly competitive. We get over 100 plus submissions, from which we end up selecting about 13 to 15. Some of the criteria we ensure is obviously it's strategic, it's a business overview, there are valuable use cases that you can learn from, and we try to provide a fairly broad overview across the entire enterprise, right? Going from strategic planning and HR to clinical population health management, financial revenue cycle management. So we've been very fortunate in that we have provided this balanced overview for the last 4 years, but of course there are always gaps or areas of opportunity. 2 of them happen to be, one is clinical care protocol design, so there was a need for that. The second thing is the vast majority of our presentations thus far have been from Epic customers. So there's again an articulated need for, hey, we need some success stories around Cerner. So we were very fortunate this year to have addressed both those needs. We had a presentation from Lehigh Valley Health System around clinical care design from Epic in a very clinical context. Today's presentation is around the same area with a very, very different perspective from Paul Lampe, who's the Director of Enterprise Analytics and Reporting at Memorial Hermann. I hope some of you also attended the presentation by Peter Smart, Senior Director from Cerner, who talked about healthy intent and a bunch of success stories around that. So with that as brief introduction, Paul, please take it away.
Thank you.
Please give him a big round of applause.
Thank you all very much for coming today. I'm excited to talk to you about some of the really cool work that we're doing at the Memorial Hermann Health System. We named this Show Me the Money and the Quality, just really to show you that we all know that in healthcare, it is about getting quality care at the best available price, right? So this is all about how we support our clinical care redesign with analytics and Tableau. Is anyone in the audience undergoing a clinical care redesign effort right now? Anybody? Okay, great. If you're not, you probably will be because it is a hot wave sweeping across a lot of health systems that are out there. So hopefully this will help you. So what we're going to talk about, I'll tell you a little bit about Memorial Hermann in case you're not familiar with us. I'll tell you a little bit about the clinical care redesign process and what we're going through and why we're doing that. I'll tell you a little bit about the strategy that we use for healthcare analytics throughout our system. I'll also talk to you about how we developed our analytics solutions and then what the benefit and the impact of this has actually gone that we've experienced and then where we're going to go with this moving forward. So let's talk a little bit about Memorial Hermann. So we're about a $6 billion company. We have 16 acute care facilities. I think this is a little out of date. I think we have about 312 actual facilities around the greater Houston area. Now some people are like, okay, you're a health system, you're only in one city. So let me put it in perspective. The area of Houston that we serve is the same size as the state of New Jersey. and then take that area and then fit this population of the state of Indiana inside of it, and that's the geographic area that we serve. So we're a pretty large system. We have around 27,000 or so employees right now. And so we're going through a lot of changes and really working to streamline a lot of the care that we give. Enough about us. So clinical care redesign, what does that mean? Well, why do we need to implement clinical care redesign? What this is this is really streamlining the efficiencies we have to ensure that we are giving the same quality care across all of our facilities at the same time that we're doing it at the best available cost, because who wants to pay more for healthcare, right? We're already dealing with healthcare being 18% almost of the GDP in the US as of earlier this year. I'm sure it's continuing to rise. And it's no wonder that we're under stress in the healthcare market about trying to reduce our costs and really handle what's going on. So we have a lot of waste. There's a lot of supply chain issues that need to be addressed. And really, if you admit it, we really are not the most efficient and inconsistent in our processes. I see heads nodding, so know we're on the right page. So we also have increasing costs, and we also have what? Decreasing revenue. So if you look at that, that is a recipe for disaster, okay? If your costs are going up and your money coming in is going down, what does that equal? Not a positive bottom line for us to continue operations. So Memorial Hermann started with a 5-year goal, which 1 year into it, we extended to another 5 years, so it's really 6 years total. And that goal is now $900 million to save over a 5-year period. $200,000 of which is part of what we call our clinical care redesign. So there's other things within that we're working on. And so I'll show you what that is. So clinical care redesign has 4 different buckets: care variation, care progression, case management, and clinical documentation improvement. So care variation, what does that mean? Making sure that if you have a procedure done at one of our facilities, that is done in the same way at every single facility. So that you get the same care, that it's best practices, evidence-based care at each facility. That helps streamline so that if a nurse goes from one facility to another, they understand the practices and the processes and the procedures, and we can measure and define and make sure that we're giving quality care in the best possible way. Care progression means taking you through the process and trying to decrease your length of stay. We have great hospitals, but who wants to stay in the hospital 10 seconds longer than they have to? Hardly anybody. There are people out there, and believe it or not, there are websites that tell you how to extend your hospital stay a long time, and they're out there. I was shocked when I heard that as well, but it's actually true. But care progression helps move patients through the care process so that if they need to be there for 3 days, they're there for 3 days. If they need to be there for 1 day, they're there for 1 day. Case management basically helps us help patients get through whatever reason that they're there in the hospital. So we help give them the resources and the tools and the knowledge of how to get better and where they should go next. What's the next level? Where should they progress to at that point? And then clinical documentation. Clinical documentation is key to getting reimbursed in the appropriate manner for all the work that you are doing. And so one of our focuses is really implementing solutions that look at how we're documenting to make sure we do get paid what for the care that we're giving. So how are we achieving our goal? Data. Data is a huge portion. Every request starts with, hey, I need to know the data. Where are we going? And I'll show you how we use that data. And we have wide dissemination of that data. So the needs that we have, we need to give data to a lot of different people at a lot of different levels at a lot of different facilities. And so we need wide dissemination of data. There's various levels of detail that we need to get. Some people need to know at the patient level. Some people need to know at a facility level. Some people need to know at a unit level. And so it's really important that we give them the right data at the right time. This data is not all in one pretty little data source. As much as we try to make it that way, I think I've heard numbers of up to 600 different systems that we have throughout our system to try to make everything that we have work. And there's a lot of different places to get a lot of that data, and we try to bring it all in together, and I'll show you how we do that. Ease of interpretation. We need to make sure that you're going to glean the right pieces of information from what we're presenting to you so that you're able to address the issue and fix problems. We have lots of different varying roles and responsibilities. Some people are nurses and clinical, and some of them are administrative and leaders, and some of them are financial. There's a lot of different roles to make healthcare happen. We need to see a high level, and then we need to find the trend, and then we need to dig down into it and find out what's really going on. And we need it to be a one-stop shop. We need to have one place where you can go to actually get all the data that you need so that you're not hunting to find the visualization. So what's the answer? The answer for us was Tableau. It checks all of these boxes. We were able to accomplish all of these through using Tableau in the solutions. So let's talk about our healthcare analytics strategy. So the first thing that we have is self-service. We are all about giving people the data and letting you go and fish for yourselves. We have over 100 users. I think we're up to about 115 or so now in our dashboard community. And so we, in our group, work through and host the server and host the publication of dashboards and dissemination across the organization. And so we help streamline that and really want to try to get the power out there to the people. But we also, in ourselves, our team works together to create the higher level enterprise-wide dashboards that you'll see today. And we want, like I said earlier, we want to give you the right data at the right time in the right role. And that's a key, because if you're delivering something to people in the right way, they can easily use it and get to it. Our goal is to spend time telling and interpreting the story, not putting it together. Our goal is to say, how many of you ever get somebody that says, okay, now can you just make it so that I can download all that data? And I said, yes, I can, but I'm not going to. And I say, look, if you want to pull that monthly and then do this and that and this and slice and dice this way and that way, let me know what you want to do. I can do all that for you. Actually, it's all the great people that work with me that are able to do that. But they have to give them a shout out. But let us do that. There's no reason for you to download it and play with it for a couple weeks and then do the same thing the next week and then the next week and then the next week. Let us do it so that we can present it to you in the way that you want it, and then it's there, it's always live, it's always ready. Data warehouse. We have a location that is one source of truth. And because it is important for us to have one place to get your data so that we're looking for it. We're not perfect in that, but we're getting there. So here's our healthcare analytics platform. This is how we deliver mostly our one source of truth. So this started out as population health. However, we have branched this out, and we are now using this for operational. Everything you see today is operational and management inside of our acute care facilities. So we take claims data, we take EMR data from lots of different EMRs. So you can tell, yes, as Andy said, we are a Cerner shop, but we also have Athena. We have partners with, our partner UT has Allscripts, there's GE, there's Care4. We have hundreds of clinics that are using eClinicalWorks. We have point-click care. So we have lots of EMRs that are out there, and it's fine, because we can take all that data. So we load that data. We also load claims. So we have our own health plan. We use Aetna, Humana, CMS, Blue Cross. We take all that data and monthly re-rolled. We load claims and enrollment into our data warehouse. We also can take on-site biometrics. We have an employer program where we actually have clinics inside of employers, and we can collect biometric data through our health navigators. We take all that data and we load it into what we call Smart EDW, which is Cerner's Healthy Intent platform. And that platform basically is Hadoop that processes and creates one longitudinal record across all of our patients. So we have a master EMPI within that data warehouse, and then we load all of that data onto Vertica, and that is the solution where all the data sits. From there, we have different applications. So we have a longitudinal record, which we call Smart Record. We have smart care, which is our care management application, and we have smart registries, which is our registries populations. We also have algorithms that are natively on the platform themselves. So we have a sepsis algorithm, we have 3M, we have Trubin. These are all groupers that we use, like the NYU avoidable ED algorithm. We have all that data loaded onto that so that we can leverage those smart algorithms on the data on the platform easily. We also have smart analytics, and that's where Tableau sits. So Tableau sits on top of our healthy intent data warehouse, and that's hugely helpful for us. And then the last thing that we have that sits on top of this is our consumer application. So the consumer application itself is what we call Everyday Well, and it is an application that we built along with partnering with Cerner, and then we also leverage third-party outsourced groups. And then that is the reimagined portal, if you will, to everything into your, to your data as a consumer. So, developing our healthcare analytics solutions, what did we do? So the first thing is, if you go back and you remember the care variation, care management, care progression, and CDI, you'll see those here, so pay attention to that. So you'll see how the pieces all fit together. So for care variation that we were talking about, we have what we call an opportunity dashboard. And I'm actually gonna go in and show you visuals of all of these later. But just understand, this is the high-level life cycle of how we put things together. So what we do in an opportunity dashboard is we look for waste. We look for problems. We look for opportunities, hence the name, to find areas where we can improve. Once we find that opportunity, we say what the key drivers are, and we identify problems. Then we have a workshop. And that workshop, we bring clinicians, so we bring physicians, therapists, respiratory therapists, physical therapists, pharmacy techs. We bring our quality group in. We bring everyone, case management, education. We bring everyone involved in the care process together in this workshop to say, okay, today we're gonna talk about sepsis. What are the best ways for us to handle sepsis in our facilities? And then they literally, for a day or two, depending on how long we actually need, sit down and tackle and have real discussions focused on what is the care pathway that we come up with. So they're driving solutions, and they're giving metrics of how do we say, are we successful or not? After that, we go and build a monitoring dashboard. So we say, great, if you say that you need to do X, Y, Z, you need to have this antibiotic given for all patients that are sepsis on this day, that's a metric. So we go in and we say, let's pull all sepsis patients, and we'll say, did they get it or did they not get it? We also have what we call order sets, or MPPs, medical power plans. Those are basically best practices sets of how do you need to go through delivering care. And they give you triggers to say, yep, you need to do this, you need to do that, you need to do this. And those order sets then help you guide through that process. Are you using those or not? Those are metrics. And so we build monitoring dashboards, and that's the majority of what I'm going to show you here in just a second, that shows you how are we doing at performing in completing the goals that we have. And that's where CDI, clinical documentation improvement, care management, and care progression fit in. So those areas don't have a workshop because it's not really conducive to that, but that's where those fit in. So cost comparison. Once we actually say, hey, we're achieving our goal, the monitoring dashboard metrics are all positive. We're achieving everything we want to do, then we look at cost. Are we actually moving the needle on cost? Are we saving money as a result of these? And then we go to our monthly operating report. So the monthly operating report shows us, are we actually really realizing the savings at the end line? So what do we do? If the monthly operating report is not showing money saved, then we go backwards and we look at our cost comparison and say, well, our cost comparison is saying in 2016, it cost this, in 2018, it cost that. Is that a real number? Well, if there's something not happening, then we step back and we go to our monitoring dashboard and we say, are we monitoring the right things? Are the solutions that we came up with in the workshop really the right thing that's gonna move the needle? Maybe giving the antibiotic on that day isn't the thing that's gonna solve that problem. So then we go back to the workshop and we say, okay, team, this is what we looked at. This solution is not moving the needle in providing quality care at a reduced cost. So maybe we need to look at something else. Maybe our assumption wasn't real. If they say, oh, I don't know, that's everything we need is there, this is what we really think it is, then we go back to the opportunity dashboard and we say, hey, was there really an opportunity there, or were we really, trying to make a mountain out of a molehill, that there was actually something that we could save there? So this is a life cycle. And if I could make this a circle, I would, and it would go around and around and around, and it goes backwards as well. So this is the life cycle that we live as we release every clinical work stream that we do care redesign on. So let's dig into the monitoring dashboards that we have. The first one, excuse me, the first one is our opportunity exploration dashboard. So this dashboard right here shows you a balanced scorecard of reducing cost, eliminating waste, and standardizing our processes. So for example, if our average length of stay is down, that's good, right? If our cost per case is down, that's also good. If our patient satisfaction is also down, oh, that's not good. I see heads nodding, like, no, please, no, don't say that. And if our readmissions are up, those first two indicators of average length of stay and cost per case going down are not good. So we need to look at it in this balanced approach and say, okay, there's a problem, and dig into that data. So these heat maps that we have here, these tree diagrams, are showing us where are the opportunities. So the darker red there is, the bigger the opportunity that we have. The impact that we've had with this, we've identified opportunities, and the entire $200 million in care variation that we needed to have over our 5-year period were identified through using opportunity benchmark evaluations through exploration dashboards. Next up, orthopedics. So on this dashboard, and I know these are small screenshots, but we really wanted to show you this, and I'm gonna also tell you, don't ever count on any of this data being real. A lot of these snapshots were built off of stuff that was not actually tested, so don't take any of these numbers to the bank and say, oh, hey, these are real numbers. Just giving you that disclaimer right there. But this dashboard right here looks at some of the outcome measures of average length of stay, 30 and 90-day readmits, and also looks at length of stay by APRs and APR-DRGs. So we're looking at volume, discharge disposition, and the severity of the illness that we have here. As a result of looking at this information, we've been able to reduce our length of stay from 2.39 to 2.25 days. And I know some of you out there that may not deal with length of stay data a lot are saying, well, that's only 0.14 days. That's a lot. Moving that needle is a huge, huge impact for us. So that's actually a big change. Also in orthopedics, the big cost savings for orthopedics is within supplies. So there are some things like aqua mantis, antibiotic bone cement that may need to be used at some times, but may not need to be used. And so we have started to use monitoring dashboards to look at when are we using this and are we using it appropriately. The result of that is we have reduced utilization of antibiotic bone cement and for elective and primary cases from 46% to 27% and saved a considerable amount of money. Medical power plans, MPPs, what we call them, those are order sets that you may use. So order set utilization is key for us. So every MPP that we create, we monitor. So sepsis, trach and vent, heart failure, pneumonia, OB, deliveries, ortho, COPD, cabbage, we look at that on a monthly basis. And so what this chart says is this shows you what is the utilization by facility this month and all facilities, and then how are you doing directionally? Are you using it more? Are you using it less? Or are you using it the same as you did in the prior month? And we can move this through filters by different populations and look over time to see how are we using. Obviously, there's a lot of red in here, so at the time, we weren't increasing from month to month, but we overall are seeing a trend in the right direction. Because you may have 100% this month, you may have 90% this month and say, hey, that's really good, but it was 100 last month, so you're going down. So, and we have hoverovers that show you all the information below. The impact of this, we have had a 2% overall execution of MPPs used, with many increasing 4 to 10% over the last 7 months. So that's a significant increase for us. The big one's next, sepsis. This is our sepsis roll-up dashboard, and what if you guys went to the keynote this morning and looked at devs on stage, wish one of those tools that they had would have been here, would have been available when we built this, because that diagonal line on this chart shows you the people that are providing all of the care that is necessary for sepsis with 180 minutes. That was tricky to do. Devs on stage, the announcements that they make today, putting that indicator line, this would have made this a ton easier. So we're going to go home and implement that as quickly as we can. But this dashboard is a scatter plot that shows you all of the points that are care points that are being delivered for sepsis. So this is looking at the time to first antibiotic. This is from the emergency department to the MICU, the medical ICU. So if you look at this, all of these patients, it's showing you a point in time when we are ordering the first antibiotic and when we're actually delivering the first antibiotic, when we're ordering the blood culture and when we've obtained the results for that. Our goal for most of these is to have that within 180 minutes of you arriving in our emergency department. And so this dashboard shows you where we have nurses that are complying with orders, and it's showing you where a doctor is complying with that. And so our medical directors at the facilities are looking at this data to say who is giving care at the right time, and then they can address these issues and they can look for trends with these scatter plots. The impact, we've reduced our sepsis average length of stay across our system from 5.74 days to 5.64 days. And we've decreased mortality almost 1 full percent from 9.4 to 8.6%. So this dashboard links, so we talked a little bit earlier about having the high level, and that is a roll-up that maybe an administrator or a medical director would use. And then, well, what about the nurse? What about the doctor that's actually on the floor? What do they have to help? So this links to a patient view. So that patient view is here. So this actually shows you each of those data points over time for each of for one individual patient. And it shows you who the provider was, who the patient was, and you can actually go through and see all this information and sort it by units, sort it by physicians, and drill down to the patient level view. The impact of this detailed view supports a sepsis care pathway for actionable insights. So we can actually look at this and have actionable conversations just showing each individual patient, and we can talk to physicians and talk to nurses and say, so what happened here? What could we do to improve making a change in the way that this care was delivered for this individual patient? Next up is CABG. So coronary artery bypass graft. So that's it's a heart surgery if you're not familiar with it. So here we're looking at key metrics like the average pre-surgical days, the average post-surgical days, and then the average total discharge time. And so we're looking at targets. So the key here is one of the things that we're always asking folks to do is give us a target. It's great to show numbers on the dashboard, but what are people trying to get to? Maybe 10% is good. 10% is usually not good for me, but hey, 10% may be good if you're currently doing it at 2%, right? So give people a manageable target to which they can get. And that's a different type of a mindset, and we'll talk about that in a second. Also, outliers. Key for us is looking at what are the outliers that we have? Who do we need to address? Let's not look at all 150 cases that you had this month. Let's look at the 10 that really had a really far outlier event of an average length of stay. Let's see why did that happen and what could we do differently. This is pointing you to the data that we can take action on. another scatter plot that we're using. And so this is showing you individual patients as well as the whole rolled up view to find your outliers. So we're looking here, these are the outliers that we need to take a look at. And as you hover over each one of these, the tooltip shows you the detailed information that you need to go dig further and get more information. Some more cabbage monitoring that we have. We're looking at different, so this is actually looking at those, the care pathway, the medical power plans that we have, and looking at the details of different events that are happening with a cabbage surgery. So when are you taking out a chest tube? When is the arterial line discharge average happening? The central line coming out, the pacemaker wire. So when are all these different steps happening? Sorry, it's really small. When are all these events happening, and what is the trend for each one of those? And we can dig down into all the individual information here. The impact overall for cabbage is this detailed view of our patient detail in support of cabbage has given us actionable insights that our doctors are learning and growing with. Trach and vent, so tracheostomy and ventilators. We're looking here at the length of stay, the length of stay for trachs and vents, and looking at the time to trach. So how long is it taking us to trach? The result here is our Southwest Clinical Pathway Pilot Study that we've been working on has reduced our average length of stay from 34.7 days to 28 days, which is huge. Trach and vent is a very costly procedure, and so reducing those average length of stay is pretty big. Also, the ICU reduced their average length of stay from 26.5 days to 15.2. ICUs are pretty expensive, and so that's a huge, huge win for us using trach and vent data. Women's length of stay. So we have an initiative that we're looking at OB and delivery, and so we're looking at some of the data for admit to discharge and discharge to delivery time. We also have this in a length of stay monitoring scatter plot, and so we are looking at trends and finding out how data is how we're utilizing data to determine different patterns of practice within OB and delivery. As a result, we have reduced our average length of stay from 4.6 days to 2.7 days, and we've realized almost $480,000 worth of savings in fiscal year 18. And that was just a partial year. So moving on from the monitoring of clinical aspects to the benefit model. So if you look here at the top, this is what's showing you how are we actually doing on a financial basis. So this is the overview executive summary. These tiles that we have at the top, they're the key indicators. They're the ones that are showing you in the top 10 service lines that we're looking at, how many of those are we actually saving money? And how much money are we actually saving in each one of these? The first box shows you a baseline. The second box on the bottom shows you fiscal year 18, how we were performing, and then it shows you the projected annualized savings that we would have. So every month we're showing you how much do you, if we stay on the same track that we have now, how are we going to be at the end of the year on saving money? This is the executive high-level view, and then we drill down. And we can look at it by APR-DRG, and then we can further drill down into the severity of illness for each and every facility, as well as major service line work stream that we're working with. So, progress. How have we done? So, we've had lots of things, some of them financial, some of them are process, and so they're going to be getting us to that location. But for case management, we're coordinating care sooner, earlier, based on the fact that we are utilizing more data. Care progression, we've moved 4.59 to 4.52 days. That's $7.4 million worth of savings just in this first year that we've been working on this project. Care variation, we have streamlined and reduced unnecessary clinical variation through our care variation work stream. Case management, again, we're working on implementing interventions to help people through their length of stay. Clinical documentation, we're becoming more accurate because of the tools that we're putting in place and the emphasis that we're looking at on utilization of clinical documentation improvement methodologies. COPD and pneumonia, we've moved from 4.19 days to 4.03 days. Care progression, we've reduce the length of stay. This is a new way of life for us. Care, when we always talk about care redesign, this is not a project, this is not an initiative, this is our new way of life. This is how we live. Data-driven decision making. We're using data to make all of the decisions that we have now. We're telling the story and then we're using that to change. This is causing a culture change at every single level. And then the biggest thing that we did in FY18, we saved $44 million for our budgeted $40 million. So we got 110% of our goal in that year. So pretty positive impact that we had. Looking to the future, what are we gonna do? So first, don't boil the ocean. These are the lessons learned. Start small, build from there. Crawl, start small. Figure out what you need to do. Get something out there. Get feedback, then build on it. Then start to walk. Add some more things to it, and then start to run. To quote Voltaire, don't let perfect be the enemy of good. Don't have analysis paralysis and say, oh, if I tweak this and if I do this, oh, it'll be this. And I mean, it doesn't have to be perfect to be out there. Make it good and work on it, and then crawl, walk, run. Crawl, walk, run. That's hard to say fast. Agile development. Rapidly work with stakeholders. Give them something. So define some definitions, show it to them. Define some more stuff, show it to them. Define stuff. Work with them and engage them. Definitions and data governance. Make sure everyone agrees on what you're actually measuring and that they all call it the same thing. It's really, you laugh, but I spent 3 months working with my HR department and working with our health plan, telling them why the dashboard was not showing the same numbers, because the health plan looks at when they actually incurred the service, and HR says, when did we pay the bill? Those are never going to match. And so 3 months later, they got it, and they said, oh, we understand why this doesn't match now. So data governance is a huge thing. I have a whole different presentation on that. We can talk about that offline if you want. You're only as good as the data you have. It's never too early to start collecting data that is good and quality data. It takes a village. Like I said, I have a lot of team members that are here in the audience, and they are my lifeline, and so I will call on them. If you ask too technical of questions and I don't know the answer, I will not be afraid to ask them. But they're really great, and we, in the culture that we're trying to change, we're calling it think data. What are you gonna do with that data? That's what we're always asking them. Why do you want that? Well, what are you gonna do with it? Well, what action are you gonna take? Well, how are you gonna change the process? We ask these questions and they're starting to think differently. Just showing it to them isn't really enough. You have to engage to change that culture. So, roadmap for the future. I know this is starting in July. Started building this a while ago. But this is showing you each of the facilities that we have and the work streams that we're implementing. So each one of these is happening, and I couldn't fit all the facilities on here and actually make it something you could read. But these are all the things that we are currently working on and that we have mapped out for the next 9 months or so. And so we're continuing on, and I have 5 future work streams, and these come every single day. So I get probably a dashboard request or a data request or something every single week, if not once or twice a week, that we have to go through. So with that, that's the story of what we're doing with clinical care redesign. What questions do you have?
How cool a presentation is that? Huge round of applause for Paul. So we have quite a bit of time for some questions. My colleague James Terhune will take some questions on the other side. We'll flip from one side to another to ensure appropriate and adequate representation. First question.
Thank you for that presentation. When you first asked, how many of us were doing clinical care redesign, I was like, that sounds a lot like optimization too.
Yep.
Except
that's another name.
More specific and has actual details attached to it. So can you talk a little bit about optimizing Cerner kind of before and after this plan was put into place? And then I guess part 2 of that would be, have you ever tried to put Tableau on top of incident requests or enhancement requests to try to kind of cluster those design changes that people want and fold them into the bigger plan?
So, okay, so let's go with your first question. Clinical care redesign, so yes, there are two arms to the ISD asks that we put. Actually, we've created a dashboard for all of our requests that we have within ISD. They were so many that we've literally taken the tracking spreadsheet that we were used, and we've now created a visualization that is updated daily. And if you want more information on that, go 3 seats down from you, and that's the guy that's actually doing that for me. And so, but yeah, we have a dashboard that's tracking all of those requests. We've started to look at connecting to ServiceNow, which is our ticketing system, to visualize some of those things. We haven't started clustering yet, but I want to get to that point. But yeah, so this is the dashboarding, the analytics, and the data side of clinical care redesign. We have a whole separate team of people that are working with us, our clinical informaticists, our chief health information officer, our associate CMIOs. They're all working with us as well on making changes within the system. And so that's why I say it's never too early to start, because in order to make change, you're gonna have to change your system. You're gonna have to train people, they're gonna have to use it, and then I can start showing you data. So it's going to take a while to do that. And so the education of the changes that are necessary, that's the hard part.
Cool. Next question from there.
Hey, Paul. Great presentation. Can you hear me
Thanks.
fine? So with your impending merger with Baylor, do you see any of the...
Abhay, can you speak up a little
Speak
bit?
up a little bit, sorry.
Yeah. No, just asking, with your merger with Baylor Scott and White, right, do you see any change in the direction with Epic coming into the play and with your analytics and data warehousing?
So the question, I think, say that again? Sorry.
He's from Memorial Hermann, by the way.
I'm Memorial Hermann, yeah. That's okay.
Okay.
Can you tell us a little bit about the structure, your org structure of your analysts? You said you had 100 plus people trained. Are they located throughout all your facilities? Are
Sure.
they centralized?
Yeah, happy to do that. So we have a core. So the team that I work with is called the Enterprise Analytics team. We sit within the ISD organization within Memorial Hermann, and we have folks that are on our core team. So those are folks that actually deal with requests that come from anywhere within the total organization itself. From there, then we have folks that's solid line to our team, but actually work out in different departments throughout our organization. They work at facilities, departments, groups, and those are what we call, so we call the people that they do everything, the hub. And then we have spokes. So those are the spoke positions that report directly into us, but sit and work with others throughout most of the rest of the week. And then we have what we call the community, which is the overarching umbrella of everything. And so those are folks that may be in quality, decision support. A lot of those folks are here today, in different groups that are actually not ISD folks, but they're heavy users of data, and so they're using Tableau, and we support them in utilization of Tableau across the organization. Does that help?
So corollary question. So the hub can be likened to a center of excellence, right?
Correct.
Yeah. Okay.
Yeah. So and we coordinate the training, we coordinate the licensing, we coordinate publishing to the server, all the core functions.
Question.
So,
Yes, sir.
This is a good segue then. Very impressive center of excellence you've built. So along this journey, what are some of the things that you learned and challenges, and how did you overcome those?
I think the biggest thing I learned was really helping people understand how to think in a way of data. It's really hard because we're all ISD data type of people, and some people really aren't. And so I think really challenging folks to say, how do you go through and think of things in a different way through how you look at data? I get questions all the time that are like, oh, could you give me all the patients that are diabetic? Well, sure. What's a patient? Is it somebody that we've seen in our ED? Is it somebody we have in an acute care? Is it someone that we have, that we see in an outpatient? Are they part of a registry? Is it adults? Is it kids? Is it everybody? Is it an adult 18 and above? Is it just type 1 diabetes or type 2 diabetes? And I just start flooding them with questions. So that's the biggest thing that I learned quickly is we have to start training our folks to think in a different way so that they can understand data in a new in a new way and be able to use the solutions that we're creating.
Yep, great presentation. I'm George Benavente from the Villages Health, and one of the things we struggle with is data governance. And you have a totally separate presentation on that, but just curious if you can talk about the strategy that you put in place to get buy-in from not only executives, but from medical directors and other managers to really get this data governance piece going.
Specifically for data governance?
Exactly.
So for data governance, we are creating a very small, agile group that is going to be really, I call them the conductors of the orchestra of data governance. Data governance is conducted and orchestrated by us, but all the decisions are pushed out to the end users. So we are actually employing governors and stewards of data by functional groups. So you can either do it by data domains or you can do it within functional areas. We chose functional areas because when you get into data domains, who owns average length of stay? You know, you're gonna have 900 people that try to raise their hand to own average length of stay. So let me let every functional area define average length of stay, and then as we come together as a larger group, then we can say, okay, you two both think this is a definition, so why don't you talk about what the real definition needs to be? And maybe we need to further define the fields that you have or the terms that you're using from there. Does that make sense? Mm-hmm. And then executives. There's an executive steering committee that oversees all of that so that if the data governors can't make a decision, it goes to the executives. And those are executives from across the organization, and then they make the final call. The data governance office makes no decisions. We just coordinate and we pull things together. Yes, ma'am.
Hi, I'm Megan, the Los Angeles LGBT Center. Every clinician likes to think that they're providing the best care. And when we give them data that shows that maybe they might not be, they feel very persecuted by that. How did you get your teams, your line staff, your physicians, your nurses to view the data that you're giving them as an opportunity to improve rather than a punishment?
Yeah, great question. Yeah, they never think the data's right. That's always the first thing, right? Well, that's not right. Let's look at it. Let's find out why not. Yeah, no, that always happens. You know, I think the key for us was the workshops that we had. It was interdisciplinary. It was everybody. And we brought the data and we showed it to them. And I think they understood it. And I think that's how we got the change to take place, because we had them look at it and say, how can we start to make the change that we have? And it's the leadership at the medical director level within our organization. We have a steering committee, and then for each work stream, we have what we call a triad. And there's an administrative leader, there's a nursing leader, and there's a physician leader. And they're the ones that lead that effort. And they're partnered with a Six Sigma black belt or a health systems engineer. And so that team really drives the goal. And so, you know, we got a doctor from this facility and a nurse from this facility and a doctor from that facility and therapists from this place. And so and said, go back and tell people about this, evangelize what you learned today to the rest of the world, and tell them these are the changes that we're making, and this is why we're doing it. Get excited about this. And so it's really, we're trying to do it as a coordinated grassroots effort.
Yeah, so it looks like you gave some really good advice on the crawl, walk, run model. I think that applies a lot to a lot of people using Tableau at an enterprise level. I'm curious as to how you overcame some of the challenges from moving from crawling to walking. Because right now it looks like you're well running and you've made a lot of significant impacts. But could you talk a little bit of how you overcame the burdens while crawling to even get up to walking? And I think a lot of that ties into data governance. A lot of that ties in, because I'm sure as you were dealing with that, you also had to improve on those metrics and bring some value. So it may be a little bit of a repetitive answer for you, so I apologize for that. But
No. It's a fine line, and my team can vouch for me that I have no problem in saying that goes on phase 2, and they really want this, but I'm sorry if you can't tell me how within the data I can tell you that you're tracheing in the OR versus tracheing at the bedside, it's not going to be in this version. And you're going to have to push that to phase 2, and you're going to have to figure that out. And they're like, oh, okay, yeah, that makes sense. And you just let them flail for a little while, and then when we just can't come up with a way to do it, it's just not there. So let's figure that problem out, and let's just do it here. But you know what? We've got all this other great data. Let's use this. Mm-hmm.
You mentioned earlier in your presentation that declining reimbursement rates and regulatory pressures are necessitating need for more analytics. What kind of analytics have you done around those pressures, and how are you reacting?
About which pressures? Sorry.
Declining reimbursement rates, insurance reimbursement rates, and regulatory pressures.
Oh yeah, we have lots of that. So we're very ingrained in population health management. The Healthy Intent platform that we talked about, we were a development partner with our friends at Cerner, and we have a lot of different ways to look at the reimbursement and the claims that we have, and really creating that longitudinal record. So we're looking at lots of different financial aspects as well.
Hi, I'm from Martins Point Healthcare, and could you speak to some of the data quality issues you may have run into? I know in my company, you get out what you get in.
Yep.
And I'm sure you must have run into something like that. So could you speak to kind of how you went about solving that?
So I have always been a firm believer that the way that you fix bad data is show it to people. I mean, really, once you see it and you're like, well, that can't be right. Okay, we'll go look at the patient. And we validate all these dashboards that we go through. So some of these are a lot of these are pre-validation, because a lot of this is kind of up and running now, or just kind of getting to the point. But we validate to the patient level. And I tell the end users, I say, we build it, we don't validate it. You validate it. Because you're a user. I don't log into the EMR. That's not my role. I deal with the data in the back end of the EMR. So what I want you to do is, I want you to be like a doctor that's going to go in, and if you are on that sepsis, dashboard and you have patient ABC up there, then I want you to go to their record and say, is this the same data that's in there? Because that's what the doctor is going to do. And if you validate back to that point and it's bad data, so then you have to work through that data issue. And so I think showing people the data and showing them what's behind it helps them understand how it goes through. Again, doctors are there providing care. Nurses are there providing care. Data is a secondary thing for them in a lot of ways. And so I don't think people always understand how data flows through and the importance that you have for data, and how it actually comes out in the end. And so I think showing them and educating them is the best way to help get to that point.
As far as the dissemination of the dashboards into your organization, how are you doing that? Just having folks pushing it to the server, logging in, SharePoint?
Yep. So the cool, if you remember my healthcare analytics platform slide that was Healthy Intent that I showed you, we actually have Tableau sitting on top of that data mine of gold data that we have. And so Tableau server sits on there, and so we publish directly to that server and send all of our folks there. So every dashboard you saw today is actually available within Healthy Intent except for one, and we just can't figure out how to get that one in there yet, because we're doing some auto magic calculations and bringing a bunch of data in, but everything else is living out there on that dashboard. So we manage that through the security module and inherent within the system of provisioning users, and so we've created AD groups that actually show you. So it's by facility, by dashboard, by groups. There's a lot of work that's involved. Again, you're sitting in the right location. Talk to the guy 2 seats down, and he'll tell you more, because he's the guy that gets all my emails that say, hey, give access. Hey, fix this group. Hey, create this. We need this. So he can help you with that. Any other questions?
Any other questions? Okay.
Back there. Back. That's an easy answer for me. It was already there when I got there. Yeah, you know, the reason we stay on Tableau is because it meets all of our needs, and it's really the best platform that we found available for creating all this. It continues to develop and meet the needs and pushes the envelope to assist us. And the server platform is fantastic for us to disseminate that data and manage it. We have Tableau internally on a server, and we have it hosted on top of our Healthy Intent application as well.
So on that happy note, we're going to conclude the presentation. Huge round of applause to Paul.
Thank you.